partners, and friends. Good morning to you all, and my best wishes for an inspiring International Universal Health Coverage Day. It is a pleasure to host you for this annual celebration, which this year highlights the urgency of our mission with the theme Health for All, Time for Action. 11 years ago today, the UN General Assembly endorsed a groundbreaking resolution urging all countries to accelerate progress towards UHC, when all people can access the full range of quality health services they need, when and where they need them, without financial hardship. 3 years later, in 2015, UHC became the founding principle of the SDGs, marking a decisive shift forward towards a more holistic approach to health and well-being. Importantly, it was a shift that was very much aligned with where we are in the Southeast Asia region. You will recall in 2014, Excellencies and I identified UHC as a flagship priority, with a focus on strengthening human resources for health and increasing access to essential medicines. Since then, the region has led global calls to reorient health systems towards quality, accessible, affordable, and comprehensive primary health care, and was pivotal in bringing about the most recent UNGA political declaration on UHC, adopted in September of this year. The declaration recognizes that global action to achieve UHC has been and continues to be inadequate, with at least half of the world's population still lacking access to essential health services, more than 800 million people globally bearing the burden of catastrophic health spending and out-of-pocket spending, driving almost 100 million people across the world into poverty every year. Notably, it highlights that by 2030, up to 1/3 of the world's population will still be underserved, with adverse impact on an array of SDGs. This is why today we ask, if not now, then when? A message of urgency, but also of hope and opportunity. In the Southeast Asia region, between 2015 and 2021, the average service coverage index increased from 54 to 62. Between 2014 and 2020, out-of-pocket spending as a share of current health spending decreased from 42.8% to 37.9%. Between 2015 and 2019, the total population, both impoverished and further impoverished in the region due to out-of-pocket health spending, significantly reduced from 12.4% to about 6.6%. Since 2014, the density of doctors, nurses, and midwives in the region has improved by over 30%. And today, all countries regularly update national essential medicine lists. Even accounting for the COVID-19 crisis, of the 270 million additional people projected to be covered by UHC between 2018 and 2025, 110 million, that is more than 40%, are from the Southeast Asia region. By no means have we achieved or are we close to achieving our targets and goals, but most certainly we are on the right track. And crucially, we have the mechanisms and frameworks in place to accelerate progress, not least our Regional Forum for PHC-oriented health systems and the region's recently adopted Delhi Declaration on strengthening primary health care. Today, in an increasingly turbulent region and a world, we are better positioned than ever, with leaders from across sectors and at all levels recognizing the centrality of health to overall social and economic development. But still, we have many more mountains to climb. In that spirit, I urge you to access and apply our new WHO publication on meeting the unmet, launched today. And I look forward to your ongoing efforts to build fairer, more equitable health systems across our region, leaving no person of communities behind. I once again thank you for your presence, wish you an inspiring UHC Day, and reiterate WHO's steadfast support for a region and world in which every person, everywhere, can access quality essential health services without financial hardship, more now than ever. Thank you.
Thank you very much, Madam Regional Director. We are proud of our UHC progress made in the region under your RD tenure. We also note the need to build up on these initial achievements. Now let's turn to the voice from our member states. We are fortunate to listen to the progress in a country with rapid enhancement in health and UHC. I'm referring to the 23 years increase in life expectancy at birth and 70% reduction of maternity mortality rate in just 2 decades in Timor-Leste. Our keynote speaker, Her Excellency Dr. Elia Antonio de Arujo dos Reis Amaral, call her Dr. Elia, the Minister of Health from Timor-Leste, will give her remark on the topic of from commitment to country impact. Dr. Elia is not only the health minister, but she will bring many perspectives to us today because she started with physicians with clinical and health management experience. But before that, she graduated in law. And then she entered politics in 2016, starting as a professor and a think tank for the Department of Health, then Deputy Minister for Primary Health Care until her health ministership. The floor is Your Excellency.
Dr. Punham, Excellencies, colleagues, friends, universal health coverage is a holy grail of public health, and it's indeed an honor to be invited to say a few words on this most important day. The latest report from WHO and the World Bank are sobering. Service coverage is stagnating at 2015 levels, and financial hardship has actually got worse. The report called the situation alarming. Clearly, we need to do more, and quickly. Dr. Punham always reminds us primary healthcare is the key that will unlock universal health coverage. We hear her loud and clear. Timor-Leste invests over 40% of its health budget in primary health care. My new government has stabilized a new post, a Director General exclusively for primary health care. And we are rolling out an ambitious program of integrated health services. And we look forward to WHO for support. As a 20-year-old country, we are trying hard to accelerate it on the path to universal health coverage. In the last biennium, we have made several achievements. Let me mention just 3. 1. Before the pandemic, we had only 6 ICU beds, all in the capital city. There are areas which are 8 hours away from the capital. You can imagine the result if someone has heart attack in one of these faraway areas. With the support of WHO, we have now stabilized critical care units in all our secondary care hospitals. Every family is now within the golden hour for critical care support too, while we have increased the number of doctors from the less than 30 to more than 900 within 15 years. Quality remains a concern. With the personal support from Dr. Punham, we are now establishing a state-of-the-art skill and simulation center is all our teaching institution, secondary and tertiary hospital. This will build the skills of our health workers in a safe environments. Before they attend to real patients, 3. Within a year, we have increased tobacco tax by 500% from $19 per kilogram to $100 per kilogram, a huge achievement, and introduced tax on sugary drinks for the first time. This will help reduce our burden of NCDs while adding domestic revenue for the government. But we still have many mountains to climb. As we continue our journey on the path to universal health coverage, we look with humility, gratitude to our older and bigger sister country in Seattle to show us the way. Bangladesh is a development what Paris is to fashion, whatever its women empowerment and education of girls of their community clinics. We have a lot to learn from them. Bhutan keeps reminding us that compassionate care and happiness is essential for universal health coverage, that the people and planet, and more important than a narrow focus on GDP. I believe the word Asha means hope in India. We hope to use the inspiring story of Asha's to revitalize our community health voluntary program as a true bridge between the community and our health system. Every family needs a safety net during difficult times. With its generous social security system, Indonesians inspire us all, even as they embark on the journey of major universal health coverage and primary health care reform. Just like Timor-Leste, Maldives remains extremely vulnerable to the greatest threat of this century, climate change. They are taking brave measures to combat it, and we can all learn from them. Even it goes through a difficult period. Myanmar reminds us that it's critical to maintain essential health services through all adversities, not just a pandemic. Following the tragic earthquake on 2015, Nepal's tremendous response taught the world that health system strengthening and resilient health system are two sides at the same coin. In the North Korea, there is a primary care doctor for every 100 families. Universal health coverage stresses the importance of taking care close to communities and providing people-centered care. This is a fine example of these principles. Health economists love to talk about efficiency. Sri Lanka shows us that technical efficiency provides the ability to provide high-quality care at reasonable cost. And Thailand's message is loud and clear to the whole world. Universal health coverage is achievable, and universal health coverage is affordable with only a moderate injection of domestic resources. Every family can forget their money worries during times of illness. This is such powerful message. So, we look forward to drawing inspiration from all our Sierra sisters and working closely with WHO as we continue our journey towards universal health coverage. Dr. Punham, you have been a visionary leader and a strong advocate for universal health coverage. You will continue to inspire us as we take this agenda forward. Thank you, and obrigado, Bharat.
Thank you very much, Your Excellency. Your Excellency, Dr. Elia also covered not only Timor-Leste issue, but all urgent agenda for other countries in the region. It is our obligation that country, WHO, and partners to walk the talk and turning commitment into actions. And thank you for your message. We in the room, we all agree that we need the progress both in quantity and quality fronts, with happiness and comprehensiveness covering many public health agenda, including climate change, mental health, and emergency in the way toward this UHC. And we hear again and again, both Regional Director and Dr. Elia, the Health Minister, talk about mountains to climb. And this mountain is huge. It might be the Himalaya toward the UHC, but we have to climb. And Timor-Leste is not the only country within this region where the health leaders show strong determination for UHC. Let's use this opportunity to appreciate policy commitments from other member states from this short video.
Primary health care is the key of a country's health system, which is considered as the kingpin in attaining universal health coverage and sustainable development goals by 2030. The community clinic is a great illustration of a public-private partnership where locals contribute land and manage the community clinic. The government constructs a building, deploys personnel and provides supplies including medicine and logistics.
Honorable Prime Minister Shri Narendra Modi ji has time and again proclaimed India's vision of Antyodaya. Antyodaya meaning reaching the last person in the last mile. Investment in primary health care is the most inclusive, equitable and cost-effective way to achieve universal health coverage. Majority of government expenditure is now happening in the sector of comprehensive primary health care. Fulfilling the principles of Antyodaya, leaving no one behind, more than 161,000 Ayushman Bharat Health and Wellness Centers, in short ABHWCs, have been established and are transforming the delivery of CPHC.
The PHC model piloted at the Farfatol demonstration site is tailored to the needs of the individual and the community rather than promoting the belief that there is something that fits all. Instead of the patient coming to the health facility, our healthcare and non-healthcare professionals go to their homes and the communities with positive health messages and interventions.
The Constitution of Nepal mandated access to free basic healthcare services to all citizens, based on which the country has updated policies and strategies. These strategic documents have defined full spectrum of primary healthcare services from health promotion to prevention, treatment, rehabilitation, and palliative care in life cycle approach.
The shared care system will be a solution for current economic crisis by reducing the bypassing phenomena. A shared care cluster system enables the sharing of human resources, infrastructure facilities, laboratory and medical equipment for patient management, which contributes for efficient and effective health system delivery. This emphasized shared care cluster system is the best model during this economic crisis situation to maintain our strong primary health care services, which was rendered through decades.
The COVID has been a test of how health system respond to pandemic, and business as usual is not our option. Here are some social innovations that introduced during pandemic and become our new normal. First, telemedicine. Second, patients can pick up medicines from pharmacies nearby their home. Last example, community engagement. During COVID pandemic, communities and village health volunteers help us to control the spreading of disease. These social innovations are major game changer for our Thai health system.
Thank you very much. You would agree with me, ladies and gentlemen, that this message from ministers record that at the 76th Regional Committee meeting reflect the common commitment for UHC. But ladies and gentlemen, one remaining cliff for UHC mountain journey, perhaps the most difficult challenge, is how we can address health disparities and health needs that do not yet appear in the health system. I'm referring to unmet need, foregone care, and health inequity. But despite these difficulties, member states in the region have demonstrated promise to put unmet need, foregone care, and health inequity in their health policy and programs. And these efforts are documented in the new publication to meet the unmet, preparing for health equity challenges in the Southeast Asia region. Let's see another short video briefly about this publication.
To meet the unmet, Preparing for Health Equity Challenges in WHO Southeast Asia Region is the latest publication to supplement the decadal publication, The Platinum Decade, Accelerating Health of Billions, WHO Southeast Asia Region. UHC is central to improve population health and well-being for sustainable social and economic growth and sustainable development agenda. Health inequity, unmet need, and foregone care remain major challenges in realizing UHC vision in ensuring all people to obtain the healthcare they need with sufficient quality and without suffering financial hardship. A key common manifest, the lower an individual's socioeconomic position, the higher their risk of poor health and thus more suffer from health inequity, unmet need, and foregone care. The most worrying aspect of health inequity is the unmet health need, which is generally defined as people who need health services but do not use or are unable to use them for whatever reasons. Unmet health care and foregone care can result from various barriers from both supply and demand sides of healthcare and beyond the health system. Monitoring unmet need and understanding the reasons of foregone care are key components for monitoring and achievement of UHC. This publication compiles 25 case studies from the Southeast Asia region, documenting how member states are addressing the need of those at disadvantaged and marginalized population in the last decade. It synthesizes 3 major challenges and 5 action areas on how we can better address health equity, unmet need, and foregone care. And lastly, the publication identifies 5 policy recommendations for the Southeast Asia region.
Thank you very much. Now we would like to invite Mr. Manoj Jalani, HSD, and the WHO Zero Senior Management to launch this publication together in the room. Thank you very much, HSD and all senior management of the WHO Zero. Ladies and gentlemen, in September this year, just a few months ago, the WHO and World Bank launched the Global Monitoring Report on UHC 2023 in New York. May I invite Mr. Manoj Jalani, Director of the Department UHC Health System, to brief us the latest situation in our Southeast Asia region. The floor is yours.
Thanks, Dr. Mek. Can you please upload the presentation? Yeah. So good morning, everyone. So what I'm going to do is present the UHC Global Monitoring Report, which was released just before the UN high-level meeting in New York this year. This is 2023 Global Monitoring Report on tracking the progress on universal health coverage. Yeah, next, please. So what you're seeing here is the slide, the one, this is like the fourth quadrant of an XY axis. So if you, on the x-axis, you have the service coverage, more to the right means more service coverage. However, for this financial protection, more to the down, if you, so you have 0, and this is percentage of population, proportion of households that are impoverished. So what you want is that people should move up towards 0 and to the right. Okay, so that is, now what you're seeing is these dotted lines, which is like giving you where the global mean is. So the global mean for the financial protection, which is measured through proportion of households facing more than 10% of their household expenditure is on healthcare, that the global mean is 10. And for the service coverage, the global mean is 68. And so now what we are noticing is that for our global value moved from 58 to 68 for 3.8.1, the service coverage, and for financial protection moved from 11.4 to 13.5. So what we notice here is that both in the service coverage as well as in the financial protection, our region seems to be doing worse than the global mean. Okay, but let's move to the next slide. What you're seeing is slightly different picture in the sense that there are only 2 countries, India and Bangladesh, which are really worse off than the global mean, both in terms of service coverage as well as in terms of financial protection. However, 8 countries of our region, we do not have the data for DPRK, but 8 countries of our region are better off than the global mean in terms of financial protection. However, it is only Thailand which is really better off than the global mean also in the service coverage. So if you look Thailand, which is way above in terms more than 80 service coverage index, as well as the financial protection being very low there. So, but then rest of the other countries are doing well insofar as financial protection is concerned compared to the global average, excepting India and Bangladesh, which are not doing so well. Next, please. Now let's look at the service coverage index 3.8.1. Next, please. So this is providing you what is the composition of service coverage index. Now these are all proxy indicators. So for you have the RMNCAH, which is basically geometric mean of coverage relating to family planning, ANC 4 and more visits, immunization, and there the proxy is DTP3, and then child care of suspected care in case of suspected pneumonia cases. And similarly, you have for infectious disease control, we have TB and HIV, antiretroviral treatment, and then basic sanitation. The indicator relating to insecticide treated bed nets does not apply to our region because we are not a malaria endemic region. On the NCDs, we have non-raised blood pressure, and then fasting plasma glucose, and then non-use of tobacco. We do not have data on cervical cancer screening. And similarly, service capacity indexes in terms of hospital bed density, health worker density, and then IHR core capacity. We don't have enough data for access to essential medicines globally. So for these indicators, we take, for all of these, we take geometric mean of individual sub-indices, and then again take a geometric mean to arrive at the service coverage index. So let's see how we are faring on the service coverage index. Next, please. Next. So this is, of course, the global performance. This is of the service coverage of different countries. You would not be able to make out, but the green one, Thailand, really in terms of service coverage has crossed 80. But rest of them, whatever we are seeing, this is a 2021, but the pace of progress, of course, there's been an impact of COVID on this, but our overall pace of progress is not going to be fast enough to reach a service coverage index of 80 by 2030. So this is just to show how different countries in the region are doing. The legends are there, but I mean, it's country-wise scenario, but I'm sure you may not be able to recognize your countries there. But just to bring out that the pace of progress is not fast enough to reach 80, although we moved from 47 in 2010 to about 62. So it's a good 30% jump, which is good, but not good enough. Next. Now, this is the sub-indices of the service coverage index. So what you're noticing is that the real increase has come from essentially the communicable diseases. So what you see was that the service coverage index for the communicable disease was 8 in 2000, and this has gone up to 64, largely because of availability of antiretroviral treatments for HIV/AIDS, but also improvements in TB and water sanitation indices, and also in malaria endemic areas. Now, of course, that doesn't apply for malaria for us. There has been, for RMNCH improved from 59 to 69. Slight improvements, but this is seemingly, has plateaued practically from 2015. Then, in terms of our coverage for non-communicable diseases, we've moved from 32 to 53. And this is where we are really lagging behind. And then also in terms of service capacity and access, which has moved from 53 to 62. So again, these are areas where there has not been adequate progress, although overall we have moved from 30 in 2000 to 62 in 2019. So this is the overall SCI, but largely being driven by the improvements that have happened in the infectious disease sub-indices, not so much in the other three areas. Next, please. Now, this is the trends of sub-indices for countries. As I said, for us in a region with some very large countries like India, Indonesia, and Bangladesh, which contribute to almost 90% of the population, our regional mean, which is a population weighted average, seems to be impacted by the progress and performance of large countries like India, Indonesia, and Bangladesh, etc. But this is the service coverage indices of individual country. And what we notice is that the story is more or less similar in almost all the countries there. Okay, let's move on. Now, we talk on the financial protection side, and which is the other indicator. So we measure UHC progress, one on the service coverage index, another on the financial protection measured through catastrophic healthcare spending, and also through impoverishing health expenditure. So in UHC index, we talk of only catastrophic healthcare spending, but overall progress for the monitoring report, we capture both. Next, please. So what we are noticing is that in this slide, while the dotted line, of course, the global one, which is the global mean in terms of financial protection, the financial protection situation is worsening globally. It was close to 10 or 9.6 in 2000, and it has moved to 13.5. For our region also, overall, the situation of financial protection measured in terms of population spending more than 10% of their household expenditure on health, that has increased from 13.1 to 16.1%. on the other hand, which is a positive story, is that the impoverishing health spending, which is like people, a proportion of population which is pushed into poverty and those further pushed into poverty. So it's sum of both the population. Population which is further pushed into poverty and those which are above poverty line but pushed into poverty, that which was close to about 32% in 2000 has moved down to about 6.6% in 2019. Now, this largely, I mean, significantly is on account of improvement in the income levels, reduction of poverty, because the economic growth, our region has been one of the fastest growing region. There has been a substantial decline in poverty. But also we noticed that the pace of expenditure, consumption expenditure is more than twice the pace of increase in out-of-pocket spending. So what we feel is that there has been, I mean, a decline in some in the out-of-pocket spending as a proportion for populations below poverty line and those just above poverty line. So which may reflect a better targeting in terms of reduction of out-of-pocket spending for poor and not so poor. Although, I mean, the relative poverty index gives a slightly different story. So, but this story in terms of reduction of impoverishing expenditure is not really a story of success for health, but may largely be a reason for improvement in reduction in poverty in the region. But this will come out more. We are asking for more detailed, insightful analysis to know a contribution of reduction of OP on this. Next, please. Now, this is the scenario. As again, I'm breaking it country-wise because, as I said, globally, we seem to be doing very badly in terms of catastrophic healthcare spending, but that's largely because of big countries in our region, like India and Bangladesh, but several countries, I mean, all other countries of our region, the catastrophic healthcare spending is below the global average, and countries like Thailand, Indonesia, Timor-Leste, Bhutan seem to be doing pretty well, and it's less than 3% of their population which suffers catastrophic healthcare spending. Next, please. Now, this is the reflection of growing importance to the health in the region, and the government spending on health is been increasing steadily, while the out-of-pocket spending as a share of current health expenditure has been going down. And in 2014, in our region, we used to have out-of-pocket expenditure as the main factor for current health expenditure. Has no more the biggest part, but it is more the government which is spending as part of out-of-pocket spending. Next, please. So this is what we notice here is that the outpatient care and the medical goods constitute the large part of out-of-pocket spending. So the major part of out-of-pocket spending is coming from outpatient care and medical goods. Next, please. What is this showing is the spending on primary health care and from what sources. And what we notice is that in many countries, the private spending is pretty high for primary health care. You have Myanmar, you have India, you have Nepal, you have Sri Lanka, however, in countries like Bhutan and Thailand, it is the public spending which is really meeting most of the primary health care expenditure. Next, please. Now, broadly, what is the summary and way forward? So what we need is an accelerated improvement is needed both in coverage and financial protection. But I must emphasize here, very important to mention the importance of quality in primary health care. And the data shows that quality is a bigger factor than even access when it comes to those disease conditions that can be managed, those healthcare conditions that can be managed with treatment. 3/5 of those mortality in those conditions that can be managed happened on account of poor quality, and only 40% because of lack of access or utilization. In terms of needs, so we need to strengthen primary healthcare to improve coverage, particularly under NCDs, reduce our out-of-pocket spending and outpatient care, and also on NCD control. I mean, if your primary health care is good, then we can reduce the expenditure. Also, affordable medical products being available close to the communities will enhance resilience and improve IHR implementation, also enable community engagement and address inequities and unmet need that we talked of. We also need to look at new approaches for delivery of healthcare. You have telemedicine, teleradiology, artificial intelligence, electronic health records to improve access, quality, and affordability. Also, through Internet of Things, improving self-care, etc. We need more money for health and in the general government budget. And so you can, our region has only less than 11% of tax to GDP ratio, while the average for Asia Pacific is close to about 20. So that needs to go up. And also there's a case for pro-health taxes for all demerit goods. We also need more health for money, so which is more about efficiency and better targeting. And that means more spending and a higher share of spending at the primary healthcare level, and also ensuring free essential medicines and essential diagnostics, at least at the level of primary care, and ensuring improved public procurements and integration of vertical programs to bring about greater efficiencies. Right human resources team composition to meet the individual and population health needs of today and tomorrow. We talked of NCDs, mental health, emergency needs, etc. Increasing strategic purchasing and effective financial protection, particularly of vulnerable, strengthening public financial management systems, and lastly, last but not the least, is in terms of measuring and addressing the unmet needs, for which we released the publication today. Thank you so very much.
Thank you very much, Mr. Manoj Jalani, Director, Health System. We know the mixed message of progresses and challenges in materializing UHC vision. Now it's time for us to listen to stakeholder points of view. We should accelerate UHC in the time of turbulence. Let me invite Mr. Ibadat Dillon, Regional Advisor, Health, Human Resource for Health, to moderate the panel discussion. And the floor is yours, Mr. Moderator.
Good morning and greetings to all on International Universal Health Coverage Day. It's my pleasure to moderate this panel discussion on advancing UHC. I think, as we heard very clearly from Mr. Jalani, all the things we have to do to accelerate UHC, but to do so in a time where there's a lot of uncertainty and turbulence. Though COVID-19 has receded, and I think all of us are very conscious of the epidemic and demographic transitions that the health systems face. But there's also a very tenuous and uneven economic recovery. We are noticing large-scale conflicts with increased geopolitical economic fragmentation across the world, and escalating climate risks that are all putting additional burdens and pressures on health systems for countries in our region. Fortunately, today we have a panelists who, from a variety of perspectives, economic, environmental, research, and government, can really reflect this global context, but really help us think about localized actions that can also be taken. So we are very lucky to have them. So in the next 40 or so minutes, we will spend time on a moderated discussion with them as they make their interventions. If you have questions to them, please put them in the chat. We will try to take them in the Q&A. So without further ado, I would like to start with Dr. Ajay Tandon. Dr. Tandon is a lead economist with the World Bank, working in the South Asia region, with previous work with WHO, the Asian Development Bank, and appointments at Oxford and Harvard University. He is co-author of several books, including most recently and highly relevant, Going Universal, How 24 Countries Are Implementing UHC from Bottom Up. Ajay, could you share your thoughts on the dynamic and diverse economic contexts in which we seek to both monitor and accelerate UHC in the Southeast Asia region? Over to you.
Thanks very much, Ibadat, and thanks also for asking me to participate during this important International UHC Day. And so I'll focus attention of my comments more on the economic side, and in particular from the financing angle. And as has already been noted by the previous speakers, one key message about the goal of universal health coverage is that the way in which a health system is financed matters, right? So it's not business as usual. And in particular, we know that public financing, and by public financing, I mean both financing from general taxation, as well as where relevant from social health insurance, including both of those as public financing, is key for countries to make progress towards universal health coverage. No country has made progress towards universal health coverage by depending on out-of-pocket spending or on voluntary health insurance. And really that's where the economic context matters, because even though we in the health sector may not like it, but public financing for health and public financing more generally is dependent on what happens in the economy. And we've gone through a lot of turbulence, as Ibadat mentioned, not just from a health perspective, but also from an economic perspective. COVID-19 was one of the largest economic shocks the world has seen in the past 100 years. Economies contracted, public revenues went down, and also debt levels went up. And also public spending on health did go up, initially for the emergency response, and then subsequently for rollout of the vaccinations, which were quite successfully rolled out in our region in particular. However, we are seeing some scale back happening in public spending for health. So some of those increases that we saw are no longer being sustained, in part because of competing priorities, but also in part because of sluggishness in economic recovery. So the reason is that the region is actually very diverse. So in some cases, India and Bangladesh, for instance, recovered quite quickly. Bangladesh actually didn't even contract, but India has recovered quite quickly and is now the largest growing economy on the planet. But others in the region, like Bhutan and Thailand, I think only in 2023 have they now recovered their economic activity to the levels it was in 2019. And then we've also had at the other end, countries like Sri Lanka and Timor-Leste, which even in the next 5 years are struggling to recover. So just as you have long COVID, from a health perspective, there's also a long economic COVID that we need to be aware of. So all is not well across all countries, and even countries that have recovered are still going through fiscal consolidation. Debt servicing levels are quite high in Sri Lanka, in Bangladesh and India, and that means choices for public financing for health, and also more generally for other sectors, also remains tight as a result of not just the COVID shock, but as Ibadat mentioned, also the other crises, geopolitical and the like. So we are in an environment where we cannot take things for granted, and we really do need to push forward, because as Mr. Jalani was showing that UHC service coverage actually stalled during the 2 years when the pandemic hit, between 2019 and 2021, and in some countries even reversed. So we do need to accelerate progress, and challenges remain. I think the challenges again are not the same across all economies. I talked about economic growth, but as Mr. Jalani pointed out, one of the biggest challenges in our region is that overall government revenues are low in many countries, and in particular in Sri Lanka and Bangladesh and Indonesia. And in other countries, it's not so much the overall revenue, but more the priority that health gets is not as high, for instance, in India or Bangladesh or Nepal. So we do have some countries that do prioritize health, like Thailand and Sri Lanka, but others that do not. So in terms of the reaction and looking forward, I think the adjustments will have to depend on country context, and really even if there's not something specific that we can do in terms of in the health sector to stimulate revenue generation or economic growth, we do need to recognize where the bottlenecks are and so adjust our reforms accordingly. And where there is option, I think, Mr. Jalani has already pointed out, I think we do need to also ramp up our engagement on revenue raising through health taxes to reduce unhealthy consumption of tobacco, alcohol, sugar-sweetened beverages, but even of polluting fuels, that can be used, even if these revenues are not earmarked for health. The goal of these should be to reduce unhealthy consumption. The fact that they raise revenues is icing on the cake. Actually, maybe perhaps I shouldn't use that metaphor given NCDs, but it's not something that should be a necessary target, but they reduce risk factors. So there may be reasons why you may want to earmark, but even if they're not earmarked, we should. The other thing is, I think we in our region need to pay much more attention also on inefficiencies in the sector, as to demonstrate that we're able to use the resources properly. I think just having out-of-pocket spending be a large share of total health spending is itself very inefficient. It's an inefficient and inequitable way of raising revenues. Even small amounts of out-of-pocket spending will delay and deter necessary utilization of health services, especially critical for NCDs. And also, if you don't invest enough in primary health care, there's huge undiagnosed and unmet need for NCDs, for hypertension, for diabetes. These are people who are not, ending up going trekking on the Himalayas. They're going to end up in the hospital, and that is also inefficient. I think just want to reiterate the point that Mr. Jalani was making. So there are inefficiencies from that end also, and also we have challenges with regard to absorption capacity. In country after country, we see as when the health sector goes to request more resources, they say, but you're not using the resources well. You haven't absorbed, why are you asking for more money when you gave back 10% of what we allocated last year? And so a lot of challenges on that front. And I just wanted to also end by reiterating another point that I think Mr. Jalani was making, that we also have a tremendous diversity within our region of some of the best systems. You have Thailand, you have Sri Lanka, excellent outcomes, excellent things. But we also, I won't name the countries, but we also have some of the worst indicators and outcomes, but also some states and regions within countries that are really doing very well. So there's also a lot of opportunity to learn from within the region itself, in addition to learning from outside the region. But it's quite remarkable, the diversity within the region, and an opportunity to really learn from each other. So I'll end here, Vedat, and hand it back to you. Thanks.
Yeah, thank you, Ajay. Very, very important points, especially of us being sensitive in the health sector to the long economic COVID. Very clear. I'd like now to switch to Dr. Oscar Primadi. Dr. Oscar Primadi is a Chief Policy Analyst with Ministry of Health Indonesia. Dr. Oscar, you have a very historic long record in both government and working with professional associations, from the city unit health offices to actually serving as Secretary General of Ministry of Health Indonesia. In this time of uncertainty, could you highlight some key actions that government of Indonesia is taking to reimagine and reform its health system to better address evolving national global context? And perhaps you could also speak to some reflections you have for us that could be relevant across the region. Over to you, Dr. Oscar.
Thank you, Dr. Ibadat. Thank you for inviting me to this important webinar. We know that achieving universal health coverage is a global shared goal. Indonesia has strong commitment to bring together collaborative actions to ensure healthy lives and promote well-being, as well as the implementation of other health-related sustainable development goals and a target. On the implementation level, diligence, commitment, and innovation continue to guide our efforts. This includes the promotion of sustainable financing for and digitalization of the health sector. In Indonesia, we have National Social Security System, or GKN, as amended from the Constitution. We believe that this is among the most important steps taken by the Indonesian government. Since 2014, Indonesia's National Health Insurance Scheme, or GKN, has made significant progress toward achieving UHC. GKN now covers approximately 263 million people, equivalent to about 94% of our population. This accomplishment firmly established GKN as one of the world's largest national health insurance programs, offering financial protection to the fourth most populous nation globally. While national health insurance addresses the demand side of UHC, the supply side remains unattainable without sufficient healthcare professionals and adequate infrastructure. Health practitioners play a vital role in universal health coverage, or UHC, in terms of both quantity and quality, where they must align their practices with a certain standards, including treatments and clinical pathways. They are also expected to continually enhance their knowledge and skills through the continuing education. Among the various challenges caused by the geographic disparities, the government continues to strive for equal distribution of health services to ensure equity in GKN benefits. To address the supply side challenges, Indonesia is boldly transforming its regulatory framework. Since early of the 2023, we amended health laws deal with these issues. The transformation carried out includes several things. First, to allow more than 3,000 hospitals instead of just 91 medical schools to train specialist doctors. This shift towards hospital-based medical residencies represents a global best practice and is the first for our country. The second one, to ensure the quality of health practitioners, the role of medical councils and colleges is crucial. They conduct certification, registration, licensure process that are implemented by the local governments, and these activities are currently overseen by the Ministry of Health. And the third one, the government makes it is easier for doctors who have completed specialist education abroad to adapt so that they can immediately work in the health facilities within the country. Additionally, we are also revitalizing our primary care network, upgrading hospitals in the 514 cities and modernizing hospitals in the 34 provinces. In conclusion, the UHC program in Indonesia has covered almost the entire population. However, due to various disparities, the government is implementing a transformation policy to ensure equity in GKN benefits. So thank you. Thank you very much.
Thank you, Dr. Oscar. It's a very clear, concise presentation on a very wide, huge, ambitious undertaking, both on demand and supply side. I think is useful for all of us. I would just ask our people on the chat, please put any questions you may have for the panelists in our chat function, and we'll follow up on those questions. I now switch to Dr. Devaki Nambiar. Dr. Devaki is Program Director, Healthier Societies at the George Institute for Global Health, India. She's a health policy and systems researcher with over 2 decades experience working in low and middle income countries. Her work in particular focuses on filling gaps between the research community and the policy community. So Devaki, in the context that we're discussing today, could you share with us the value addition that the research community can bring to the development and implementation of health system policy, as we also heard from Dr. Oscar? Also your reflection on opportunities present across the region to strengthen policy-relevant research. Over to you.
Thanks, Sabadat. I can try. So as must be evident, I'm a researcher, and research is meant to be the systematic generation of knowledge from a particular context, but also knowledge that allows for lessons to be derived beyond that context. And on this occasion of UHC, happy UHC Day, everybody. If we think of the UHC as a cube, my submission is that the role of research is one where we walk around that cube and we're trying to look at two things in particular that I'll focus on here, but more can be done by way of research. One is how full is the cube and where are the gaps? And the second is how can we be filling the cube and how are we filling this cube? What's working for whom, under what circumstances? So on the first point, just to give you an illustration of the role research has played, Ajay got into this to some extent, but there has been some research done in some published work in 2022 focused on the UHC service coverage index that Chelani sir also presented that really points towards some of the fundamentals that Ajay raised, including in the context of our region. So the use was of the UHC service coverage index, which has been pointed out in the chat, has some important limitations. Be that as it is, this research has revealed that the service coverage index in our region has obviously a positive correlation with GDP and a negative correlation with poverty and unemployment. And so the shocks that are being introduced, economic and otherwise, conflict, climate related, will have bearing on our ability to advance on the UHC path. Interestingly, a piece on the fundamentals, you saw the sub-index on service capacity and access. That in the study in our region, which includes our region, shows that the service capacity and access contributes significantly to the overall index. And that is perhaps where we need to be placing some of our emphasis. Another kind of question that research can answer is who is covered and who is not. So our region is one where there's a very large informal sector. In a 2023 review of low and middle income countries in our region have found that existing insurance models really have a missing middle, and that we are leaving a number of people behind. In my own research in the context of South India, we found that among poorest quintiles who are rightly targeted by insurance, there remains out-of-pocket expenditure. It persists. And in fact, while we have decline in out-of-pocket expenditure in overall terms, we are still not able to remove it for people through our existing coverage mechanisms. And it's not just informal sector workers, right? As has been mentioned by other panelists, there are other groups being left behind that research can start to reveal. Migrants and refugees, conflict and climate affected populations, historically marginalized groups like ethnic, religious, and gender minorities, as well as those living in remote locations. And so research across the region is showing these gaps. And the effort to conduct research is showing that there are gaps in data. Some of this is not even being looked at yet. And that's sort of my fourth point. And really, I think one of the key messages of the report launched today on meeting the unmet. So there are gaps, there are critical gaps in coverage, and that are actually accompanying this critical data gaps. So even in the slides that Chelani sir presented, you saw there was a real range and even availability of data. So a 2023 publication by, this is focused on India, this had self-reported data from populations as well as clinical triangulation. It found that as many as 48% of the sample had never had their BP measured. And only half of the medication required annually was received by those with chronic ailments. NCD is the big elephant in the room in terms of data gaps and our understanding of unmet need in the region. And this, of course, has been raised by Ibadat, you and others in a 2023 publication, and is one of the areas where progress is stagnant. Data reveals that. Another area where we lack information is on the private sector. We've been hinting at it, but there's a real need to enhance our ability to capture what's happening in the private sector and what its impact is on our path to UHC. Getting to my next point, and I'll try to be brief here, but research has a key role in helping identify what works for whom under what circumstances. And given the great variation within and across countries that Ajay was talking about, we really need a lot of nuance in terms of research method to understand this. Policy research we have done in some countries of the region reveal important lessons. For instance, in Bhutan, cervical cancer policy making appears to emerge as an opportunity to improve gender mainstreaming in the health sector overall. You will hear Dr. Oscar's comments about Indonesia's initiatives in center staging health equity, Sri Lanka in its work on health inequality monitoring. This has the opportunity to improve our progress, not just on target 3.8, but goal 17 as well on disaggregated data. So these are important advancements that are happening in our region that we need to understand and document more carefully. Population-based research has shown the critical role of primary healthcare reforms, which many speakers, including Her Excellency, the Minister, has raised in the context of Timor-Leste. And indeed, the pivot towards primary healthcare has really increased across the region in recent years, impressively in countries like Timor-Leste, the Maldives, even DPRK, which was mentioned by Her Excellency as well. You can see this in terms of even research output. We did an indexing of research on primary healthcare, and it found that between 2013 and 2023, research output on primary healthcare in our region increased sixfold. But we also saw that international research funding is dominant in our region. So this is a change we perhaps need to focus on, research funded in our region that supports the needs and priorities of our region. I'll close with a few points. The people in our region are the real torchbearers of UHC. Community participation, and research has found community participation, the importance of voice, the role of local self-governments, frontline health workers and community volunteers was manifest and really played a critical role during the pandemic and continues to play a critical role beyond that. We have to create enabling contexts for these important stakeholders on the path to UHC, giving voice, understanding need, giving access to and control over technology and more. I'm part of a researcher implementer consortium called the Sphere Consortium, and we are finding in our research that institutionalization of social participation has been key. Our region has some real pathfinder countries in this space, from Nepal to Bangladesh to Thailand. Our work is now focused on understanding how countries have achieved this and what kinds of supports and costs this has entailed as we make this broader argument to the world and take things forward. Finally, I'll say that we as researchers have a responsibility to generate and integrate research around the UHC cube that is context sensitive, that draws on our regional strengths, engages with the plurality of knowledge and medical systems we have in our region, and helps create a learning exchange within and across systems. And we can't do it alone. So I would close about that by saying that in the interpretation of more than ever, we are perhaps saying that focus on UHC is more important than ever. But one way that we as researchers are seeing it is that we need more stakeholders than ever, and we need to work together. And that's what I hope for as we journey into the coming year with UHC. I'll end here.
Devaki, thank you. I think you were very clear on highlighting the gaps we have, the challenges, but opportunities to have research that is more aligned and maybe better funded from our own region. Now I would like to switch to Ms. Manjeet Sohal. The fourth panelist we have is Jeet Sohal. Ms. Sohal currently manages the Climate Health Program in Southeast Asia for the coalition Healthcare Without Harm. Prior to joining Healthcare Without Harm, Ms. Sohal supported the Government of Philippines Disease Response and Social Protection Program. I think something that really came as a surprise to me is that Healthcare Without Harm Asia has had an over 20-year focus mission to transform the health sector to become climate resilient, sustainable, and low carbon. Manjeet, you have just returned from the UN Climate Change Conference, COP28. Reflecting on discussions in COP28 and the current context facing countries of the Southeast Asia region, could you share your perspective on opportunities present for the health sector in not just contributing to, but leading the environmental justice agenda? Over to you.
Thank you so much, Dr. Idabad. Happy UHC Day, everyone. Today is also the last day of COP28, and negotiators are still working on the final details of several negotiated work streams. This COP was historic for health, as it is the first ever day. Almost 2,000 people out of the 80,000 plus that came to COP this year were health delegates, either health professionals or coming from health organizations. And 50 ministers of health, first time ever, attending the first ever ministerial meeting for health. And from that meeting, a climate and health declaration was launched with over 140 countries endorsing it. And with this declaration, countries committed to a number of objectives, including ensuring that all the work that we do on adaptation and mitigation in the health sector contribute to combating inequalities, including working to achieve universal health coverage. And the health community is playing a very crucial role in this fight for climate and environmental justice. Health professionals, as you know, are usually some of the most trusted voices in their communities. When doctors, nurses, hospitals, health systems take public stances on environment and climate change, it can reframe these issues as questions of public health and help move public opinion and public policy. So leading up to COP28, we saw 46 million health professionals calling on the COP28 presidency to commit to an accelerated, just, and equitable phase out of fossil fuels. Our health allies are still on the ground in this last few days in Dubai, ensuring that the core message of fossil fuel phase out and the imperative of prioritizing health in climate negotiations remains at the forefront. And in doing that, in being part of the global climate negotiations, in having the health community fighting for environmental justice, as we advocate for all of these issues at a global stage, we must not forget the fact that health systems in the developing world are still grappling with the challenge of providing basic health services to their populations. And that gets me to my first key message. Until everyone everywhere has full access to high quality and affordable healthcare, the health sector must continue to grow. And that growth should mostly be happening in the developing world. It seems simple enough, but as everyone here knows, it's not. The problem is, and this is where Healthcare Without Harm and our work comes in, we can't afford for that growth to follow the same model that it has so far. I mean, the resource-intensive and incredibly polluting model would deliver healthcare. In terms of climate impact only, this amounts to a sector that is globally responsible for almost 5% of net global greenhouse gas emissions. If it were a country, we would be the 5th largest polluter on the planet. And this is part of the study that we conducted in 2019 with ADROP. At Healthcare Without Harm, we have modeled how these emissions would grow in a business as usual scenario. And if we continue down this path, health sector emissions would more than triple by 2050. Which brings me to my second key message, that we have a twofold challenge ahead of us as a health sector. We need to rapidly and profoundly transition to low carbon healthcare, but without compromising patient care. And we need to continue advancing health equity while making sure that the expansion of health coverage is designed and carried out in a fundamentally different way. And when we talk about fundamentally different way of delivering healthcare, at Healthcare Without Harm, we mean investing in health systems that are deliberately designed and built for climate resilience and pandemic preparedness. It has been mentioned by the other speakers on this panel, we need health systems that are able to absorb the growing demand for health services in their own workforce, operations, and infrastructure. They need to be able to withstand an increasing number of climate impacts that are ever growing in frequency and severity. When the storm comes, they need to be the last building standing. Health systems must also be ready to respond to the next pandemic. COVID-19 was not the first, and it will not be the last of the great pandemics we will be facing during our lifetimes. And yet what we saw, and what other speakers have already mentioned, in terms of how it pushed our health systems everywhere to the limit and reversed decades of development gains, all of these will be dwarfed by what we could be seeing in a few years in terms of health impacts of climate change. For the past years, we have seen progress in this work in transitioning to low carbon and climate resilient healthcare. We are continuing to witness and help generate growing momentum with over 80 countries now part of the Alliance for Transformative Action on Climate and Health, or what we call ATTACH, which is a WHO organized network that came after the COP26 health program in Glasgow in 2021. More than 25 of those countries have committed to net zero healthcare, including Indonesia. Countries in CIARO are leading this work. We are seeing members of ATTACH from CIARO have already started or completed their vulnerability assessments and health national adaptation plans. And some of them are already calculating their greenhouse gas emissions as a health sector, whether at the facility level or at the system level, using tools such as those that we developed at Healthcare Without Harm. And we have health systems representing 14,000 health hospitals, health facilities all over the world, committing to net zero emissions by 2050. We also convene a global network of hospitals and health systems around the world called Global Green and Healthy Hospitals, who are all committed to environmental sustainability. So there is a lot of progress. We now need to accelerate that progress and turn ambition into action all over the world. Thank you so much, Dr. Idabad.
Thank you, Manjeet. I think very important words, and I think even for myself, it's really valuable to keep this agenda in the forefront of our mind as we think about the health sector and health systems. So thank you. We will quickly try to address some of the questions. There's many. Our time is little, but I will start with Ajay. Ajay, there's a range of questions on financing and its link to equity in the chat. If you could just provide a reflection as you're looking at some of these questions. Over to you.
Sure. Thanks, Ibadat. So let me try. So there was one question on health taxes, the double duty for taxes and subsidies, and how can the health sector advocate for these? So just briefly wanted to make this point that basically not just health taxes, but you sometimes may want to reduce subsidies, say on fuel subsidies, and Dr. Oscar can give you insights from Indonesia, which they had a massive reduction in fuel subsidies. So, but however, in all the countries that I have worked in, usually ministries of health are not that engaged in the setting of health taxes. The goal, and so what happens is Ministry of Finance ends up setting these health taxes, and their objective is to maximize revenue. So they end up trying to set taxes in order to get the most revenue. However, the way in which you want to evaluate these policies, and the reason you want to evaluate these policies, including with other policies reflecting messaging and making it difficult to purchase these things, is to reduce their consumption, not to raise their revenue. The fact that they raise revenue is a positive externality, but really the goal should be to reduce consumption. And I think there's been a lot of success in our region, including in India, for in terms of tobacco smoking reductions, but also much more needs to be done in other countries. Very interesting sort of things happening. Bhutan used to ban tobacco, but has sort of removed that ban, I think, during COVID, and is taxing and the like. But really, we do have a lot of evidence that well-designed health taxes work in terms of reducing consumption. In fact, they are some of the most cost-effective interventions for reducing risk factors. And that's how they should be cast. And the fact that some taxes, so there's another question on whether the taxation is regressive versus progressive. The basic point is that many indirect taxes, that means taxes on consumption, tend to be regressive. Regressive meaning the poor end up paying a higher share of their income on those taxes than the wealthy. However, direct taxes are not regressive. So direct taxes are taxes on individuals, on income, on wealth, on property. And so the focus of reforms really should be on making taxation progressive. That means expanding the use of direct taxation on income and wealth and the like. And also adjusting your indirect taxes so that you're also trying to make them progressive. So you can design them in a way that luxury products are taxed more, but also not just looking at taxation alone, but also the benefit incidence of spending from that taxation. So you want to make sure that the benefits are accorded more to the poor than to the wealthy. So in a net sense, your benefit incidence becomes Thanks.
Thank you, Ajay. Just conscious of the time, so we're trying to just wrap up quickly. Dr. Oscar, there was an important question in the chat that's linked to our discussion on unmet healthcare need. The question was really around, there were two questions. One around how do we better understand user perspective? And the second one was really that a lot of our health system is around chasing incentives, whether it's the health professionals or whether it's the patients themselves. So the question asked that, what can we do that a population is perhaps not that interested in seeking out preventative, promotive, palliative care? And why is this and what can we do? HSD, this question also came in, what should WHO be doing to address this issue? Is that clear, Dr. Oscar? Maybe I will speak. How can we better understand the user perspective, and are there other means to get people to uptake services of prevention and promotion and palliation that is not based on incentives? But what are the issues and challenges? I don't know if that's clear.
Yeah. Yeah, regarding promotive and prevention and the palliative in the nation. So we have some scheme for that one. Yeah, financial incentive, providing financial incentives, increasing the utilization of healthcare services can be achieved through the various policies that are in incentive-based, promotive, preventive, and palliative. Here are an example of policies in each of those dimensions. Incentive, financial incentives, providing financial incentives to individual or specific groups to use healthcare services, such as a discount or subsidize for health checkups or medication. Health insurance program, encouraging the population to use healthcare services by providing incentives through affordable health insurance programs with significant benefits. The promotive, community awareness campaigns, conducting education and health promotion campaigns to raise awareness about the importance of regular health checkups and maintaining a healthy lifestyle. Health education program, organizing health education programs in communities to provide information and education on how to maintain health and the importance of routine healthcare services. In preventive, mass vaccination, conducting mass vaccination campaigns to prevent communicable diseases that can be prevented through vaccines. Health screening programs, implementing health screening programs to detect diseases at an early stage and prevent them from progressing to more severe palliative condition. In the palliative, improve access palliative care services, providing and enhancing access to palliative care services for patients in need of long-term health care. Psychosocial support, organizing psychosocial support programs to assist patients and their families in coping with the challenges and stress related to serious or chronic illness. It is important to note that these policies can complement each other and are preferably implemented as part of a comprehensive health strategy. Additionally, active engagement from the community healthcare providers and local governments can strengthen the impact of these policies in improving healthcare services utilizations, and promoting public health overall. Periodic evaluation and policy adjustment are also crucial to ensure their sustainability and effectiveness over time. That's right, Dr. Ibadat.
Dr. Oscar, thank you. I think a very clear, important point on how we have to really think differently of the services and how we organize them, including community engagement, psychosocial support, as we think about prevention, promotion, palliation. Now, we are out of time, but just any key message, concluding message from each of you, 1 to 2 sentences, 3 sentences that you really want everyone to take back from this discussion. Over to you, Manjeet, please. Just key point for us to take forward.
Thank you, Dr. Idabat. I think just as a key point, the climate crisis will hamper any achievement we have on universal health coverage. And so in ensuring we leave no one behind, we need to reimagine the way with which we deliver healthcare, ensuring it is low carbon and climate resilient, prioritizing preventive over curative measures, and strengthening and investing in primary healthcare. Thank you.
Thank you. Over to you, Devaki.
Thanks. I'll echo what Jeet is saying, and just again, if we can bring that cue back into our imagination, I think thinking about population coverage more in terms of population participation and linking up to unmet need, service coverage, thinking about the platform that primary healthcare provides and the ability to locally customize. And in financial risk protection, I wonder if in our imagination, hoping to reduce impoverishment, we can also think about sustainability and planetary considerations as part of the risks that we run in not following through.
Thank you. And Dr. Oscar, final thoughts from your side?
Yeah, I think Indonesia's low reforms are a significant step in balancing the supply of healthcare practitioners. Health practitioners, so crucial for achieving the equality in our healthcare system. This reform not only increase the quantity but also the quality. Yeah, quality of health professionals, health practitioners, ensuring better healthcare for all Indonesians. Yeah, and then I think this is a key point that we must move reform. From to. It is thank you, Ibadat.
Thank you, Dr. Oscar. I think finally last to you, Ajay, and last concluding thought for us.
Sure. And I hope, Dr. Oscar, you mean health not just for Indonesians, but for everybody in CRO and everywhere in the world. And I just want to iterate the point that he made, that I think quality is very important, quality of services, especially for reducing out-of-pocket spending. And by quality, I mean, broader, not just clinical quality, but, opening hours, accessibility of services and the like. And also very briefly that there's a lot of evidence to suggest that incentives matter, and even small levels, so you want to have negative user fees. You want to pay people for prevention, promotion, conditional cash transfers. They can be very powerful incentives. So we need to think beyond just reducing out-of-pocket spending to actually even paying small amounts to incentivize utilization, among the other things that are already mentioned. Over to you, Ibadat.
No, thank you, Ajay. Thank you, all of us. I'm looking at your 4 pictures, and coming in my brain is climate, people, health professional, incentives with quality as a combined theme. So thank you very much. I'm passing over to Mr. Jalani to take the floor again. Thank you to all our panelists. Also, sorry, to Dr. Mek.
Thank you. I'm a gap filler because we need to adjust the room a little bit. Thank you very much for Mr. Ibadat and all panelists for such a great session. And we all learn a lot, and we know that this is how to accelerate the progress, how to address the gaps, and many more need to be done. And then I would also recommend all those of you online to study all the comments. Some are recommendations, some are note for warning, some are note to concern, but we can learn from this chat that is accumulated experience from all of us here. Ladies and gentlemen, now we are moving to the end of our webinar. We would like to invite Mr. Manoj Jalani to conclude and give the final remark. SSD, you have 3 minutes.
Thanks, Dr. Mack. I think my job has been made easier. Firstly, I mean, it's difficult to summarize and conclude because so much of wisdom and a lot of key messages. But Ibadat capturing the key messages from each of the individual panelists, so I don't really have to further summarize what are the key messages from them. So, well, I mean, basically what we realize is this is the time for action for UHC, and the times are indeed turbulent. I mean, we heard about the economic crisis, once in a century economic crisis. We are also looking at the climate issues. We are also looking at crisis globally around the world. Of course, our region is relatively not so affected. And in this time of turbulence, we have to accelerate our pace towards UHC and make a case for greater advocacy there. RD mentioned about good progress, yet mountains to climb, and centrality of health to overall socio-economic development. Her Excellency Timor-Leste showed how the country has moved from commitment to country impact, and there has been a sizable increase in the budget and a big thrust towards primary health care, and again, the kind of UHC reforms that the country has taken, including on increasing pro-health access, and particularly on tobacco and sugary drinks, etc., to address the NCD related issues. And then we had this important area which was touched around the unmet need, and this also came out in discussions of our panelists as to how we need to address as to who is really being left behind and why, and how do we address that, and also need for greater research and addressing the data gaps towards unmet need to be able to really address this important gaping hole, which is currently not measured in our UHC indices. With that, and my 3 minutes are up, so over to you, Dr. Mack. Thank you.
Thank you very much. Thank you very much, Ajati. And thank you very much for all of you, all speakers, all panelists, and all of you who participate in this event. Happy UHC Day. And it is UHC now more than ever. Thank you very much.
Happy UHC Day. Thank you.
Thank you. Thank you very much.
Congratulations.
Very well. Can you all stay for 2 minutes?